the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Please note that you are placed in listen-only mode, so if you have questions during today's presentations, please submit them via the Q&A portion of the WebEx, and we will address them at the end of the event as time allows. The slides from the webinar, as well as a recording of the event, will be made available on the provider page of our website by tomorrow afternoon. And we also thank you for your participation in a brief final poll that will be issued during the last few minutes of today's event. Today, we're joined by Corinne Thompson, co-lead for the Epi Data Unit of the agency's COVID-19 response, who will speak about recent epidemiology of COVID-19 in New York City. Dr. Jane Zucker, Assistant Director of the Bureau of Immunization and Vaccine Section Branch Director for the agency's COVID-19 response, who will speak about COVID-19 vaccine booster doses and vaccination for children ages 5 to 11. And Dr. Mary Foote, Health Systems Planning and Strategies Lead for the agency's outbreak response, who will discuss outpatient COVID-19 therapeutics and other updates. So with that, I will pass it off to Dr. Foote to begin.
Hi, good afternoon, everyone. Thank you so much for joining us. Next, advance the slides. And I wanted next slide. All right, and I will actually turn it over right now to my colleague, Dr. Thompson, to talk about the more recent epidemiology updates in the city.
Hi, everybody. Let me share my screen here. Okay. You can see my screen, right? Yeah, okay. All right, so hi everybody, my name is Corinne Thompson. As mentioned, I am one of the co-leads here of the Epi Data Unit, and I also lead the group that puts out this webpage. So it has been a while since I've been here, so I'll just go through the most recent Epi and also sort of walk people through the webpage. It's been updated a little bit in terms of the structure. So overall, this is our webpage. We have a couple of different tabs up here. The most interesting, I would say, are the latest and vaccines at the moment. We also have information on variants trends since the beginning of Data by Zip, which you can explore on your own. But I'll spend some time here on the latest page, which I think has the most up-to-date information. And before I go a little bit further, I just do want to highlight that you can download all of the data that we put up here. We update on a daily basis during the week, and we have not only all of the information available for download, but we also have a very extensive data dictionary here that will explain what the data is, where it comes from, and then common questions. So I would love for everyone to explore that and then get in touch if you have questions. So overall, the Epi recently is actually looking pretty good, where things are declining overall, which we're very happy about. So instead of looking at this table, I think the best way to look at that is through our Epi curves here. So this is an Epi curve of cases by diagnosis date or specimen collection date. The confirmed cases are shown in blue and probable are shown in the gray here. So you can see overall definitely a trending downward. We're currently at less than 1,000 cases a day, which is great. We're hoping that holds. Hospitalizations also trending downward. We've had some data bumps recently, so the last couple of weeks here are a little bit less trustworthy, but we're low and stable for hospitalizations, and then also low and stable for deaths as well. We're at about 10 or so deaths every day by date of death here, which is definitely much, much lower than previous waves. So again, overall, a declining metrics, which is great. And then happy to share, this is one of our newer elements here. We have weekly rates shown here by a couple of different groupings. So the first one I'll show you here is by vaccination status here. You can see there's a drop down. So the first is vaccination status. The unvaccinated rates are shown in purple. The rates among vaccinated people are shown in orange. And then we can see the rates overall are shown in gray. So the first here is case rate. So you can see weekly case rates by vaccination status. Main take home here is that overwhelmingly unvaccinated case rates much, much higher. Not surprising, but good to be able to show this data. You can see that we do have cases obviously in our vaccinated population. Stable case rate, slightly declining, so about 50 per 100,000 every week, but certainly much less than our unvaccinated population. And then we also have the same for hospitalizations. Again, same message, unvaccinated population, a dramatically higher hospitalization rate. Vaccinated population, a much lower hospitalization rate here, especially compared to cases. So we know that although there are vaccine breakthroughs, the risk of hospitalization or death among the vaccine breakthrough cases is very low, which is great news. And then similar trend here for deaths overall. Again, death rate much higher in our unvaccinated population and very close to 0 for our vaccinated population, which is very good. I will also just point out here, that's weekly data. We also have total and averages since vaccination began. So if people are more interested in the actual raw numbers, we have tabular information here of the overall counts and then the rates. You can see the rate of cases compared to among the unvaccinated in purple and among the vaccinated in orange here. So would like to highlight that if you are interested. Also want to point out by age, we can take a look. I know that as Dr. Zucker will talk in a minute about the PEDS vaccinations, which is very exciting. So we do want to highlight the testing once school began. Testing among the especially school-age population really shot up. So we saw a pretty dramatic increase. This is the 5 to 12. I don't know if you can see my cursor, but this is the case rate among 5 to 12-year-olds, which you can see there is peaking sort of end of September. This is driven primarily due to increased case finding in this population because of increased testing in this population once school started. But you can see a nice decline there in the 5 to 12s, 13 to 17, same thing. And overall, most age groups are declining, which is very good. Hospitalizations, I'll just point out, still the highest rate of hospitalizations in the oldest population here, not surprising. Very low hospitalization. This is the 5 to 12 group here. You can see very low pediatric hospitalizations, which is very good news. And then death, again, most commonly in our elderly here, and then essentially non-existent in our young population here. It's close to 0 for the pediatric population, which again is very good news. Also can highlight race and ethnicity. Again, the case rates, we have the highest case rate in our white population. This may be because of ability to access care or pay for care here, so interpret this with a little bit of caution. Again, most race and ethnicity is going down. Same pattern here in the hospitalizations. We do see an increase of Black and African American New Yorkers have had the highest rate of hospitalization over this third wave here compared to the other races, though they're declining too. And then death rates, you can see Black and African American overall highest in this third wave here, followed by Hispanic Latinos, but everybody is trending nicely downward over the recent couple of weeks. And then I will also just show quickly, one of the things we're keeping our eye on is this is percent positivity by zip code. And one of the things we're keeping an eye on is an outbreak or an elevated percent positivity in some of the Orthodox communities. So you can see here, this is Flatlands, Midwood. We also have sort of smaller clusters in parts of Williamsburg and Borough Park here, although it's hard to see at this resolution. So overall, everyone is mostly, for the most part, going down, which we're very excited about. And I think we have a whole bunch more data here if you're interested. Testing rate, hospitalization rate by zip code as well. So if you're interested in maps, I'd definitely point you here to the latest map section. And then testing, overall percent positivity. This has sort of become less of a daily number that people pay attention to, but we are very low percent positivity. And again, you can see here we have by age, test rate by age, tons of information that I'd like to point out for you here. And then just to highlight, this is not the data that my team puts together, but more Dr. Zucker, but we do have a lot of data about vaccinations, which I'm sure hopefully most of you are aware of on the same page. And I guess the last thing I'll say is just in terms of variants, we have, when we started reporting variants a couple of months ago, this was sort of more interesting, but you can see here, Delta is by far and away the most common variant that we are identifying in our sequence cases and will probably remain so for the foreseeable future. So I will stop there because I know there'll be a lot of interest in the pediatric vaccination talk, but I'm very happy to answer questions in the chat as we go. Thank you.
Great, thank you so much, Dr. Thompson. Okay, so I just wanted to start out. Am I able to share screen? Okay. Oh, great. Okay. First, we're just going to give a couple quick updates. I have been the planning lead for the therapeutics that are being distributed, particularly through the federal government program So I just wanted to start out by showing you some new resources that we have available, talk a little bit about some of the new therapeutics that are coming out that you've probably been hearing a lot about, especially this week, and then give a quick update about flu season. So I will just share really quickly. So first of all, this is just wanted to direct you to on our COVID-19 provider page off of our main website. And you can access this down on the left-hand menu. There's the information for providers. And then from there, you can click on the outpatient therapeutic tab, and you will see all our new and existing resources on primarily on monoclonal antibodies right now, but this is where we'll be adding information on the oral antivirals and other therapeutics as they become available. So just wanted to make sure everybody was aware of that. We have also a information leading you to the Height site resource, which is a monoclonal antibody treatment site locator for sites within the greater New York City area. And that was just updated. So there are actually a lot of additional sites added if you haven't been on here in a while. And so really encourage you to take a look at that. So you're well versed on where you can refer patients that would be eligible. And in addition, we have some just additional materials for patients. When you're talking to your patients about monoclonal antibody treatments. So just wanted you to direct you to that. And I'll stop sharing. Okay, and then next slide. Okay, so I'm really going to focus on the two products that are very close to authorization. These are two products. One is an oral antiviral. One is a long-acting injectable monoclonal antibody, which will be aimed at pre-exposure prophylaxis. So these two products are both going to be provided for free by the US government. Allocated states will be, at least starting out when supplies are limited, there's going to be allocated doses by state, and then New York State is going to be allocating resources to the different jurisdictions within the state. And then starting out with the oral antiviral, molnupiravir. So this is a product by Merck, and this has a EUA application pending. The review by the FDA advisory panel is going to be on November 30th. So we are expecting authorization could come as early as the first week of December, with distribution starting right away, as there are doses already procured by the US government. So they're pretty much ready to go as soon as the EUA is established. And so this medication is very interesting. It is not COVID specific. So this is for RNA viruses. It is a ribonucleoside analog that essentially the viral RNA polymerase mistakes this for a building block and incorporates this molecule into the proteins that they're into the RNA, and then that disrupts replication. So it basically disrupts the reproductive process of the virus and does not allow it to continue to reproduce in the body. So this is a drug that will be sort of similar in administration to Tamiflu. So it'll be a twice daily for 5-day regimen. And similar to the monoclonals and Tamiflu, time is really of the essence. So the sooner you can get it to the patient after symptom onset, the better the impact will be. And then the next product is another one we're really excited about. This is a long-acting monoclonal antibody, and this will be able to be given by intramuscular injection. So this is a combination of two long-acting products, and the likely dosing will be, we anticipate, every 6 months. And this will be primarily targeted to patients with severe immune compromise that would be very, very prone to severe COVID infection if they did get infected. So this is our, again, very exciting. This is our first pre-exposure prophylaxis product that will be available. So if you do work with particularly high-risk patients, you would probably want to start identifying and talking to patients who would be eligible for this about coming in for treatment. Okay, next slide. And then just want to talk about the flu, some updates for flu season. So right now, we have not detected much in the way of flu activity in New York City or New York State. And kind of looking at the Southern Hemisphere, who is kind of coming out of their flu season, we did not see a lot of activity in parts of the Southern Hemisphere, but a little bit more than last year, but it still seems to be well below regular seasonal baselines. However, we just really want to caution that the Southern Hemisphere activity is not always predictive of what will happen in the US. Especially when there's so much variation globally between non-pharmaceutical interventions, travel restrictions, etc., that can impact transmission of flu. So basically, we're saying be prepared for a potential uptick in flu cases this year. And just speaking of vaccines, I will just say be prepared to offer flu and COVID vaccines together, especially now that we have not only first dose options, booster options, and children vaccines possible. And there's data to say those work effectively when administered together. And then also right now is really the time that we would like you to start testing for influenza in addition to COVID-19 in patients coming in with flu-like illness, so we can start to be able to detect if there is flu circulating. So it's great for surveillance. And also for clinical decision making. And then I would say now is the time to really make sure that you're reaching out to your patients at higher risk for severe flu or COVID, which is pretty overlapping risk factors, that it's one, they need to get vaccinated for flu and COVID if they are not already, and consider if they're appropriate for boosters, and also really counsel them that it's really important that if they do develop symptoms that could be consistent with flu or COVID, that they need to get tested right away so they can access timely treatment if needed. So, and that especially is true, now that we have both Tamiflu for influenza, and also we're going to have some treatment available for COVID-19 very soon. And then also just want to remind everybody in terms of prescribing antivirals for flu, Tamiflu and Bloxavir in particular are the main oral options. So when flu is starting to circulate in the community, really consider prescribing if you have a high-risk patient and you have to make some clinical decision making, definitely consider prescribing empiric Tamiflu based on clinical diagnosis of influenza. Particularly in patients that are at high risk for severe complications or are having progressive illness. And this is really, I think there's a lot of thinking about don't give it after 48 hours, but in these populations with progressive illness or at high risk, just give it no matter how long the duration is if you have confirmed or highly suspected flu. And I think that's it for us. And then I just wanted to highlight at the bottom reference, the CDC has put up some updated guidance on flu testing and treatment. So I encourage you to take a look at that to make sure that you are ready to go if we start having flu circulating. And with that, I will turn it over to our main event, Dr. Jane Zucker, to give us updates on the COVID-19 vaccine. Thanks.
Thanks, Mary. Hi, everyone. My pleasure to be back and participating in today's webinar. And we have a lot to cover, so let's dive in. Next slide. Corinne showed you the website. All this data is there. We have over 12.1 million doses administered. If we're looking at adults, it's really pretty amazing, all the successes, and it's really been You know, many of you who are on the calls, contributions to this to reach 87% of adults having had at least one dose of vaccine, and 79% are fully vaccinated. And if we look citywide, we're at 74% of people with at least one dose, and 67% are fully vaccinated. So really tremendous accomplishments. And the next slide, Corinne showed, so we can skip over that, just again reinforcing that, right, the risk factor for getting COVID is not being vaccinated, primary risk factor. So let's dive into booster recommendations. So now CDC recommends COVID-19 vaccine boosters. So now it's all adults who receive the Johnson & Johnson or the Janssen product, and some adults who receive the Moderna and Pfizer. You can use any of the FDA approved products for that booster dose, regardless of primary series. So that's the mixing and matching heterologous series, and just the timing of when you give the booster depends on which primary series was received. So next. So for the mRNA series, and the people for who should receive a booster was certainly for the people 65 and older, and for people in long-term care facilities. This recommendation was based on evidence of sort of increasing disease and potential evidence of waning immunity among these populations. People 50 to 64 with underlying medical conditions were also included because of their, that if there was waning immunity, we didn't want to wait to see it, but want to get ahead of it with booster doses, since these are people who are at greatest risk for, again, complications and mortality. The next group in terms of may receive a booster, and this was for people 18 to 49 who have underlying medical conditions, and then people 18 to 64 with increased risk of COVID-19 exposure and transmission, either from occupational or institutional settings. And really, this part of the recommendation was really to allow for physician discretion and allow physicians who thought, who felt, based on their individual patient's medical condition, that they should receive a booster and they were at higher risk. So having this as part of the recommendation gives providers that flexibility. And it's the same in terms of the exposure settings. The occupational, in particular, the conversations were around healthcare workers and concern that even if a healthcare worker gets a breakthrough infection, they're vaccinated, get breakthrough infection, they can't work. And that by preventing additional infections, you're really helping to preserve the workforce. So that was, again, part of the logic for these recommendations. The booster for an mRNA vaccine should be administered at least 6 months after completion of the primary series. Next, for the J&J primary series. So this is really, this is much simpler. Everyone who did get one J&J dose, 18 and older, should receive a booster dose at least 2 months after the primary series. And this is also just, we haven't seen the same evidence of waning, but just the one dose of the vaccine had a lower vaccine effectiveness, and the manufacturers have shown data that with 2 doses, you get vaccine effectiveness up at the same range as the mRNA vaccine. So that second dose is really designed to sort of boost that vaccine effectiveness. Next. So just want to highlight the, this table for the Pfizer vaccine. The dose for the primary series and the booster is the same as it is for the Janssen. If we can go ahead one slide, just one click for the highlight the Moderna. So the Moderna primary series dose is 100 micrograms. That's 0.5 ml, but the booster dose is half of that. It's 50 micrograms or 0.25 mLs. So I think that's just important for, in terms of people's workflows in clinics, that people are getting the appropriate booster dose. And also it's a 50 microgram dose, regardless of what product was used for the primary series. Next. So again, as mentioned, they did allow for this heterologous mix and match. And so again, if you got Pfizer, you can get Moderna or J&J. If you got J&J, you can get either of the 3 products for your booster. There was not a preference made by either FDA or ACIP or CDC. Just want to distinguish from those additional 3rd doses for severely immunocompromised people that those people should receive the same vaccine product. So again, if they got 2 Modernas, a 3rd Moderna for that 3rd dose, and same for Pfizer. One change in the interim recommendations that came out is that people who have gotten 3 doses, because they are moderately or severely immunocompromised, are eligible for a 4th dose. And that would be, again, the same guidance 6 months after that 3rd dose. So that's, again, that would be a total of 4 COVID-19 vaccine doses, and that's an except, really the only population for which 4 doses are recommended. Next. So again, there's no preference. CDC has a nice section in the clinical considerations about what might be some of the considerations for a provider to make a choice about the product. So whether, just taking into account some of the rare adverse events that are associated with the vaccine products. So for example, with the J&J product and thrombosis with thrombocytopenia, the highest risk is among women 18 to 49. That may be a group to consider giving an mRNA vaccine to. But again, a J&J can be used, and the same thing for Guillain-Barré for men 50 to 64. And on the other side for mRNA vaccines, since the risk of myocarditis and pericarditis is highest for males 12 to 30. Again, boosters are only recommended 18 and older, but again, this might be a group. Maybe you consider a J&J. But there'll be next slide. There'll be a lot more data coming out on the heterologous series, and those are recommendations that I expect will change over time. So exciting, we now have a vaccine for children 5 to 11 years of age, again under EUA. Next. So, I think this is just an important slide, just highlighting the epi of COVID-19 in children. A lot of conversation at ACIP was, again, around the misperception that kids don't get, sick from COVID. Why do we need, to vaccinate them? What is the risk benefit? But just really a reminder for everyone, that 9% of all the cases in the US have been in this age group. And we're talking about over 8,000 COVID hospitalizations and 94 COVID-19 deaths. And again, these deaths are now vaccine preventable. By being able to vaccinate this population, we can also, address multi-system inflammatory syndrome in children, which are over 5,000 cases. Just under half of them were in this age group. And again, MIS-C, has occurred more often in children who are Hispanic or Black. And it can again occur after asymptomatic or mild infections. And also children are also subject to post-COVID conditions, which impact them. And so again, this may have long-lasting impact on these children. And then again, the role that children play in transmission of SARS-CoV-2, both in households and in the school settings. Next. So the pivotal trial data that was presented to the FDA, there were 2,268 participants. They had started enrolling children in June this year. So that's important because that's when the Delta variant had predominated. And the median follow-up for these children were 2.3 months. And the dose for children was, they did dose finding, and the dose is 1/3 of that used for people 12 years of age and older, and it's 10 micrograms. And the efficacy against, and this is symptomatic COVID-19 among children, and these are among those children with no evidence of prior SARS-CoV-2, was 90.7. So my automatic light went back on, which is better. So we'd have to get up for that. But so that, again, just to clarify, this is among the people who had no prior evidence of infection. So next. So again, the safety and reactogenicity data, there were no flags. There were the reactions that we expect after vaccine. Most reactions after vaccination were mild to moderate. They resolved in 1 or 2 days. The 3 most common post-vaccine side effects were injection site pain, which again we expect, fatigue, and headache. And these were comparable to what was seen in the 16 to 25-year-old Pfizer recipients in the trials. They also had an additional 1,000+ children. FDA had asked Pfizer for an additional cohort for more safety data. And so that safety cohort is over 3,000 children. And there were no severe adverse events attributable to vaccine among these children. And there, because of the enrollment timeline, there was much less follow-up. And within the 7 days when you would often see the severe adverse events, none were identified. Of note, no cases of myocarditis or pericarditis. That's been one of the big questions. But again, the study population really was not large enough to detect any rare events. Next. So based on this data, FDA issued the emergency use authorization on October 29th. ACIP met on November 2nd to recommend use of the vaccine in all children in this age group, and then CDC endorsed the ACIP recommendations later that evening. Next. So just I really want to highlight some issues about the pediatric formulation. So this is a different vaccine product. It's in a different buffer than the vaccine that's being used for 12+. And there are color coding, to try to really distinguish the vaccine so that we don't have any medication errors, right? We don't want to give an adult dose to a child. And so this sort of shows you, the vial cap color for the adult vaccine is purple, it's orange for the 5 to 12. And then again, the dose for adults is 30 micrograms and it's 10 micrograms for children. If we can, next slide, so we can highlight the injection volume, which is again different than adults. It's 0.2 mLs. And then next, the amount of diluent that's used, if you can go to the next, is 1.3 mLs, different than what's used for adults. So this is all really important right, again, in terms of just the training in your facility, that these differences are clear to people who are handling the vaccine. And just also because of the dilution, adult product cannot be used for children, right? It's just not possible to draw up a small, accurate small volume to give children the right dose. So that's like a big, never use adult vaccine for children. Also, the pediatric has 10 doses per vial after dilution. And then just click one more time. I think what's really, I want to highlight, we've gotten lots and lots of questions about this. The good news with the new buffer is that the vaccine is more stable. So this vaccine can be stored in the ultra cold freezer for 6 months. There's no longer a freezer storage option. But the good news is the vaccine can be stored in the refrigerator for 10 weeks, up to 10 weeks. And this is a regular vaccine storage refrigerator at the regular temperatures. So we're really hoping that this easier storage, more flexible storage, will really allow more pediatric care providers to enroll in the program and to order this vaccine. Next. And so for the dosage, it's based on age, not size, and not weight. So children should get the appropriate age-appropriate formulation, and it's based on the child's age the day they come for vaccination. So if a child was 11 for their first dose, right, they got a 10 microgram dose. If they're 12 when they show up for that second dose, they get the 30 microgram dose. That's CDC guidance, AAP guidance. However, if a child does receive the 10 microgram dose for that second dose, it doesn't need to be repeated. That's a sort of change in sort of the administration errors that they're allowing for this dosing. The FDA EUA also allows for dosing of either 10 or 30 micrograms, but the recommendation is to use the 30 microgram dose. Next. Really important that we co-administer COVID-19 vaccine with other routinely recommended vaccines. You know, Mary brought this up earlier, especially now, you know, we're a lot of vaccination for flu, missed opportunity if we don't get vaccines at the same time. Also for children, you know, many children are behind on their routine immunizations. And so, you know, the advantage of giving sort of multiple vaccines at one visit, right? You sort of, you know, can get people, you get their children caught up. And really, you can just administer, you just have to administer the vaccine at a different injection site or in different limbs. We can get a COVID vaccine in one arm and flu in the other. Next. So just, I wanted to say just a word about the risk of myocarditis. That was just a focus of the ACIP conversations. So in terms of after COVID-19 vaccine, obviously vaccine is just really starting for under 12. That risk was greater for the 12 to 29 years of age. And typically we've seen it after a few days following receipt of the second dose. And patients should seek medical care if they develop symptoms consistent with myocarditis or pericarditis, right? Chest pain, dyspnea or palpitations. This should be part of the counseling. But, you know, looking at the potential risk for this age group, it was determined by CDC and FDA that any benefits of vaccination would outweigh these risks. A lot of discussion that if you look at the epidemiology of myocarditis just pre-COVID, that really it's lower in the 5 to 11 and that it does increase, you know, with increasing adolescent age, and that also with the lower dose use for the children that the risk would be lower as well. So that, I mean, that will obviously be seen in the surveillance data. You know, that will be followed very closely as it has been, you know, throughout the vaccination program. Next. So the considerations for children with a history of COVID, this is similar to adults, right? Even children who've had prior infection should receive the vaccine. And again, this hasn't changed. If someone has COVID, they should wait for their vaccination until after they've recovered from their acute illness. And also they've met the criteria to discontinue isolation. And, you know, there's, you know, increasing amount of evidence about the benefits of vaccination, even, you know, for people who were previously infected, and that vaccine gives, you know, a sort of more protection, right? So if you have a group of people infected, the risk of reinfection is higher among people who were not vaccinated than compared to people who were vaccinated. There were children in the trial who had previous evidence of infection, and there was no difference in terms of their side effects, and they did have higher post-vaccination antibodies. And just again, serologic testing is not recommended for purpose of making decisions about vaccination. You know, the tests are different. They're measuring different antibodies. You know, not all the tests are quantitative. The tests are not approved for this purpose, and we don't have a good correlate of an immunity as we would with measles to know how to interpret the serologic test in terms of protection. So please, you know, we're hearing about this a lot, but providers should not be getting serologic testing for this purpose. Next. So there's also the considerations for children, adolescents with a history of MIS-C. This is not changed for the guidance. You know, that the recommendation is that benefits are likely to outweigh any risks. Children should have fully recovered, and, you know, they have to like meet all that criteria, and that includes returning to normal cardiac function. But, you know, this decision should be made, you know, in collaboration, you know, with the child's care team who are caring for them for MIS-C, for MIS-C. But that otherwise is the same as it had been. Next. So I think the summary is, that the benefits of vaccination for children 5 to 11 clearly outweigh the risks. We're talking about benefits in preventing cases, preventing likely, hospitalizations, MIS-C, deaths, post-COVID complications, possibly impacts on transmission. And that'll also provide people with greater confidence thinking about returning to school and those important social interactions. Some of the data, from CDC was that, we often look at the number needed to vaccinate to prevent a case. And, the numbers were that we need to vaccinate 10 children to vaccinate 1 case of COVID-19, which is really great sort of, balance in favor of vaccination. And really the risks, based on all, the, millions of doses that have been administered of just COVID-19 vaccine, risks of vaccine, are rare, and that we, myocarditis, are also rare events and expected to be even less common among the 5 to 11. And then there is the short-term reactogenicity, which again is, mild to moderate and short-lived. Next. So just want to say a few words about, in terms of the operations we were given the ability to pre-order vaccine before the ACIP vote. And so we had sent out a notice and asked providers to pre-order vaccine. We had a minimum order size of 300 doses for the first pre-order. And so really anyone who ordered 300 or more doses were included in those first orders. For people who go on the ordering screen, the pediatric vaccine has to be ordered separately. Next week, all the minimum orders will be 100 doses. We do have some vaccine that we've brought to our pharmacy, and we will be sending that out. So providers who've ordered 300 or more as part of that pre-order will get shipping notifications from CDC for when the vaccine is coming. And then again, as we get our third wave shipment, we will start redistribution to providers who ordered 100 or 200 doses. A question I got today was about storage, especially for pediatric offices. Again, the vaccine can be stored in the same refrigerated unit with other pediatric vaccines. So it could be stored with your VFC vaccine, your private vaccine. The best practice, we recommend for VFC, right, that you should have the vaccine in a separate container in the refrigerator so that it's clearly labeled COVID vaccine and it's clearly labeled pediatric COVID vaccine. I know for many of our sites, we actually bought cute little orange containers to sort of match the caps to sort of have clear sort of visual cues to prevent any medication errors. We have had wide distribution. There's also distribution through the federal programs. So really all provider types have gotten, were part of that pre-order were included. We're talking about hospitals, federally qualified health centers, provider offices, independent and chain pharmacies, our city vaccination sites, urgent care. So really the idea is we really want to have as many vaccination sites as possible and really have as many pediatric care offices as possible so that children can be vaccinated in their medical home. And information on the program and enrollment is on our website, and the link is here. And we are posting all this additional information about, the vaccine storage, ordering, the minimum order sizes on the website as well. Next. So I want to say a word about medical exemptions from, again, what I've been hearing. Because there are mandates, whether it's for work, travel, or school, that some patients may request a medical exemption in lieu of being vaccinated. And just a reminder that really it's only valid medical exemptions that should be provided. There are very few contraindications to vaccination. You can refer to the CDC clinical considerations. But I do know that employers and institutions are reviewing these requests. Certainly for the city, there's a centralized process for doing that. And, I only say that patterns of inappropriate exemptions that we're told about will be investigated. And I'm sort of adding that because we see that with exemptions requested for school and childcare. And so I wouldn't be surprised if there are some providers who may be perhaps providing a lot of inappropriate exemptions. So just a sort of caution, and really all providers should not be writing medical notes that are not correct and accurate. Next. So updated contraindications. So this part is the same if you have a severe allergic reaction. This didn't change or a known allergy to a component of the vaccine. So these are people you wouldn't vaccinate, and you can consider referral to an allergist or immunologist. The next slide is the precautions have been updated. And this I think we have a box around. The change for precautions is this non-severe immediate allergic reaction after a dose. That was a contraindication. This is now a precaution. And this is based on all of the experience we now have with these hundreds of millions of vaccine doses, and that it is safe to, consider giving vaccine to these people. The recommendation is for a 30-minute observation period, and you can also consider referral to an allergist or immunologist prior to vaccination. Next. And so this is just hasn't changed people without a contraindication or precaution. So again, if you have an allergy to oral medications, any other sort of environmental exposures, family history of allergies, these are reasons, these are not valid contraindications. You can proceed with vaccination, although, people will have a 30-minute observation period if they've had prior history of anaphylaxis. Next. There were also some updates to what are acceptable vaccine series for people vaccinated outside the US. So again, if people were vaccinated with an FDA approved or an authorized WHO vaccine, we consider them fully vaccinated. The changes, they were not accepting the mix and match. So many countries may have given an AstraZeneca followed by a Pfizer, but that is now acceptable. These people would be considered fully vaccinated. People who got one dose of an FDA-approved vaccine overseas can get the second dose in the US. And also the booster dose recommendations are somewhat complicated for people vaccinated outside the US, but essentially they're only recommending boosters if you got an mRNA series or the J&J series, so that it lines up with the US guidance. But they're not recommending boosters for people who got only WHO-approved vaccines at this time, although that may also be updated in the future. Next. So I think the CDC brief is just really important, sort of just laying out the benefits of vaccine-induced immunity compared to infection-induced immunity. I think for both groups, there's really lower risk of reinfection within, the first 6 months that they've studied, but that, again, the accumulating evidence that full vaccination has led to more consistent and higher titer and antibody response compared to the SARS-CoV-2 infection. Again, we don't know what those protective levels of antibody titers are, so it's difficult, again, so you can't get a serology test to determine that. But again, even in the face of Delta variants, the recent studies done during this period have just shown, that again, there's protection, both post-infection, post-vaccination, but, any reduction in efficacy is modest, and we have sort of sustained protection against hospitalization, severe disease, and death. But again, the evidence that vaccination does reduce the risk of reinfection, after vaccination, even in previously infected people. And, there was studies out of Kentucky. We have some data that will be, have been released by the health department, and that was included in this science brief, just showing an increased odds of reinfection for people with prior infection who are not vaccinated. And again, CDC recommends vaccination for all eligible people, regardless of those if they've had prior infection. Next. So just looking forward, we've been waiting for FDA review of the Moderna application for 12 to 17. They've been asking for additional safety data from experience in Europe. Moderna has had a press release talking about the vaccine efficacy for children 6 to 11. but they're waiting for that EUA filing until there's a decision on the 12 to 17. And then of course, Pfizer is enrolling children in studies under 5 now for vaccine effectiveness. And so we'll see that trial data could possibly be available early next year. And so as we know more about the developments, we'll make sure to keep the provider community informed. Next. Yeah, so Mary said this earlier, but it's time to recommend flu vaccination. We do, not only do we have a vaccine finder for COVID vaccine, but also in this vaccine finder, people can search for flu vaccinations. You know, you should offer flu vaccine, you know, at every patient encounter. If you don't carry flu vaccine, then you should refer them to the vaccine finder. Really, a lot of independent pharmacies, all the chain pharmacies all have flu vaccine. We'll make a plug here that our pediatric flu vaccination is really lagging behind where we were last year. And so really with, you know, the possibility of a flu season starting soon, or possibly a more severe flu season, it's really important to get kids vaccinated now. Next. And again, we have lots and lots of resources on our website, including provider access line. You know, I think you've all seen this before. And next, I want to make sure we have time for questions. I think that should be the last. There's one. Can we go to the next slide? Just information for CME. And I guess I'll leave it, Allison, how you want, you know, to go over the CME for folks. And then next, I think that's, we go to Q&A.
Yes, this is the last slide, so
Okay.
we have about 9 minutes for Q&A.
Yeah, great. Right, so I know I talked sort of New York quick, but I want to make sure there's time for Q&A. And I know people, I'm gonna check the chat as well and see what's left. So anyway, Allison, I'll turn it over to you for questions. You want to moderate the Q&A?
Sure, thank you, Dr. Zucker. And I know, yeah, we still have Dr. Foote with us here to assist with Q&A, as well as Jennifer Rosen, who I hope folks have seen has been answering some questions in the Q&A as well.
Hi, sorry. And just if you are putting questions in the chat box, if you could also post those in the Q&A so the rest of the audience can see them, that would be appreciated. But thank you, Dr. Zucker. That was fantastic as always. I always learn so much listening to your presentations. So I'll start going with some of the more recent questions that may not have been responded to yet, but first question is about the intranasal flu vaccine. Is it still going to be available or recommended this year?
Yes.
Excellent. Short and sweet. I like it. And then let's see. There were a couple questions.
We do have doses through the VFC program for providers who may be participating. Okay, great.
And then we did have some questions about the buffer for the pediatric vaccine. Is the buffer preservatives is one question.
Just preservative free. You know, the pediatric vaccine has to be used within 12 hours and then it's discarded.
Okay.
So there's no preservative. You know, and the buffer really doesn't change anything. The buffer is just sort of offered more stability. You know, and I think that 10-week storage in the refrigerator is really pivotal, right? That's just a real major just advancement in terms of really being able to broaden the range of providers that can actually store the vaccine.
Great. So yeah, so that's just one question to piggyback off that. So just ask to please clarify when a Pfizer pediatric vaccine is diluted, how many hours should the doses be used in? So I think
it's 6 hours for the adult product and 12 hours for pediatric.
Fantastic. Thank you so much. All right. And we got a couple questions interested in any thoughts on when the Moderna might be approved for pediatrics.
You know, they submitted the EUA in June, and I thought it would have happened a while ago.
Yeah, same here. Then in terms of supplies for the Pfizer pediatrics, there was just a question about what does our supply look like in the coming week or two. And should there be concerns about wastage for pediatric vaccines given the supply limitations for now?
Yeah, so there's no supply. So I will say that there's enough vaccine, like at the federal level, that we don't have to worry about supply. We're not in a shortage situation. Our initial allocation was like roughly, enough for a third of, like, one dose for a third of all the kids. So, we just, we're expecting to be able to order, get allocations weekly and to be able to process orders the way we were doing for adult, several times a week. And we don't, in terms of wastage, and I know it's really, really hard to waste vaccine. And I know especially, for such a product we've been waiting for, and as we started in a shortage situation, but we really don't want to have missed opportunities either. So, we don't want children to not get vaccinated because you don't want to open a vial because you're not sure you can use all 10 doses. So we really call this responsible wastage. And, the most important thing is getting, children, getting people vaccinated and not being concerned about wastage. Our wastage overall in the city is really still quite low. So, this is not a primary concern anymore.
Okay, great. Thank you so much. Okay, and then there is actually a couple questions about the therapeutics that just to give you a your voice a rest, Dr. Zucker. So there was a question about when will the Pfizer oral therapeutic antiviral get EUA recommendation. So I mentioned that it wasn't written down, but there is a scheduled meeting with the FDA advisory panel on November 30th. So once that happens, we expect the EUA to very quickly after. So that's why we are saying expect likely authorization by the first week of December. And like I said, it will be ready to immediately start shipping from there because the US government has already procured doses to start with. And production is being ramped up quite quickly. And just in terms of other exciting oral therapeutics, you may have seen very hot off the presses. Pfizer has also just announced results from their oral antiviral trial results through press release. So we don't have any peer-reviewed publications on that yet, but it showed actually even better performance in terms of reduction in hospitalization and death compared to molnupiravir. So we're very excited about that. And now that we have their interim analysis, they should be pretty much immediately applying for an EUA. So I think that approval will probably come very quickly too. Okay. Dr. Rosen, do you have any interesting questions you wanted to highlight? I see you're furiously answering.
Yeah, so I want to just go, if I may, Mary.
Yes.
So on Vaccine Finder, the pediatric Pfizer is a separate option for a choice so that anyone going on the Vaccine Finder will see which sites are carrying the pediatric Pfizer. So that will be, and we will be doing a survey with providers if they want to also be listed on Vaccine Finder, and we'll be checking in with everyone about which products they have so that we could list them appropriately on the Vaccine Finder if that's what they want. All the city sites are reporting to CIR. It's really in real time. So, unless they had some connectivity problem and they had to go to paper. But if there are specific examples about children who they know were vaccinated at a city site and it's not in CIR, you should let us know about that because that's really important. But there is all of that app they use is connected to CIR. So again, if there are reporting issues, we really want to know about them.
Great, and I think that's pretty much puts us at time. Thank you so much for all your great responses to these questions, Dr. Zucker. And I just want to let you know there is still a lot of, I'm sure hopefully a lot of interest in the oral antivirals. And at our next webinar, which we have not scheduled yet, but it will likely be in the beginning of December. We will be very focused in giving a lot more information on the new therapeutics that are coming out. So stay tuned for that. And
Mary, I'd like to just say one more thing.
yes, please.
So just for next week, we're planning at least 2 sessions around the pediatric vaccine. Really, instead of the health department giving a talk, we really want to have sort of office hours for providers, because again, we've gotten lots of questions about particular storage, refrigerated units, and we think that having open hours for questions might be a way that we can get people answers quickly. So we will be sending out notices about that.
Great, thank you. That's very helpful. So Allie, if you don't have anything else to add, I will just thank everybody so much for joining us. I know everybody's really busy, especially this time of year. So I hope you guys all, since we won't see you before, have a great and wonderful Thanksgiving holidays. And we'll see you soon. Thanks.
Okay, thank you. Bye.
Bye.